Hello, my name is Helbert Rondon and I am a nephrologist at the University of Pittsburgh. We're going to talk about practical aspects of the evaluation and management of inpatient hyponatremia. I have no disclosures. The learning objectives for this talk are: number one, to interpret key laboratory parameters in the diagnostic workup of hyponatremia. Number two, identify patients with SIADH who are unlikely to respond to fluid restriction. And number three, describe preventive and therapeutic strategies for overly rapid correction of hyponatremia. The outline for this talk is: first, we're going to talk about the diagnostic workup of hyponatremia. Then we'll move to discuss the general overview of the treatment of hyponatremia and the management of SIADH more specifically. And finally, we'll finish the talk talking about prevention and management of overly rapid correction of hyponatremia. We're going to start with a case. John is a 32-year-old drummer with a past medical history of depression and alcohol use disorder, who is brought to the emergency room after found down in his living room with several empty cans of beer next to him. His vital, his blood pressure is 121/68, his heart rate is 73, he's altered and has a slurred speech. He has mild scleral icterus but no other signs of chronic liver disease. And his labs show a sodium of 123, BUN of 6, creatinine of 0.5, a glucose of 80, a plasma osmolality of 280, which is normal, a total bilirubin of 1.7, a urine osmolality of 85, and a urine sodium of 18. So the question is, what is the most likely cause of John's isoosmolar hyponatremia? Isoosmolar because it's normal osmolality in the plasma. So the alternatives are A, hypovolemia, B, high triglycerides, C, cirrhosis, or D, beer potomania. And the right answer is D, beer potomania. Now, you ask, well, beer potomania is a type of hypotonic hyponatremia, but John's plasma osmolality was normal, 280. That doesn't make any sense. Well, the issue here is that we should not confuse plasma osmolality with plasma tonicity. And this is one of the problems that we're going to discuss in the next few slides. But first, I would like to talk about the classic hyponatremia diagnostic algorithm that was developed in the 70s. This algorithm calls for the sequential analysis of the plasma osmolality, followed by the assessment of the volume status, and finally the assessment of the urine sodium. If we follow this algorithm with the information provided about John, then we're going to say that we're on this branch where the plasma osmolality is normal, 280 to 295, and therefore this is an isotonic hyponatremia. And the diagnosis is some sort of pseudohyponatremia caused by either high triglycerides or high protein levels in the plasma, such as in multiple myeloma. However, this is incorrect because we already said that the diagnosis is beer potomania. So this is one of the problems with the algorithm, which we're going to enumerate in the next few slides. So my advice is, do not follow this algorithm. Rather, think of hyponatremia in terms of physiology. What's going on with water homeostasis in this particular patient? So don't use this algorithm. Well, let's talk about plasma osmolality. Plasma osmolality just means the solutes or particles that are dissolved in plasma. And the main solutes dissolved in plasma are sodium, glucose, and urea. And there is a formula to calculate those. If you remember, plasma osmolality equals to 2 times sodium, and sodium values are given in milliequivalents per liter. And when you multiply by 2, you are accounting for the anions that accompany sodium that also contribute to the osmolality, and those are mostly chloride and bicarbonate. Milliequivalents per liter can be transformed to millimoles per liter or milliosms per kilogram. Now, then glucose you divide by 18 and BUN you divide by 2.8 to transform units from milligrams per deciliter to millimoles per liter. So everything is in millimoles per liter or milliosms per kilogram. So these are the three main solutes in plasma. However, when we're talking about tonicity, we're talking about something different, which is not the same as osmolality. Tonicity refers to those particles or solutes dissolved in plasma that contribute to or have an osmotic effect, which means that they're able to pull water out of the cells when their concentrations in plasma are high. And in order for those solutes to do that, then they should be unable to cross cell membranes. And sodium doesn't cross cell membranes. Glucose doesn't cross cell membranes when there is absence of insulin, so in diabetes. But urea does cross cell membranes. Therefore, urea doesn't contribute to the tonicity or effective osmolality. So when we're talking about tonicity, we're talking about effective osmoles, the ones that can shift water because they cannot cross cell membranes. So urea doesn't do that. So if we can differentiate between solutes that contribute to the tonicity versus solutes that do not contribute to tonicity, we have to know what is the distribution of those solutes in the body. If those solutes are able to cross some membranes, therefore distributing in total body water in the column on the left, then they will increase the plasma osmolality, but they will not increase plasma tonicity. What are those solutes? Urea, ethanol. Very important. This is the case of John. John had a beer poromania, which is hypotonic hyponatremia, but at the same time, he ingested ethanol and was intoxicated with ethanol. That's why he was found with some empty cans of beer in his living room. Therefore, the osmolality of ethanol made the plasma osmolality normal, even though he in reality had a hypotonic hyponatremia. Toxic alcohols can do the same, all right? And on the right, you'll have solutes with distribution in the ECF, in the extracellular fluid compartment only, which means that they are unable to cross cell membranes. And they will increase the osmolality, but also they will increase the tonicity. What are those solutes? Glucose in the absence of insulin and mannitol. So this is the main difference between osmolality and tonicity. Okay? Alright, so plasma osmolality, how do you interpret that? If the plasma osmolality is less than 275 milliosms per kilogram, that is always hypotonic hyponatremia. Okay, so that's easy. But if the plasma osmolality is 275 or more, then this could be hypertonic hyponatremia, it could be isotonic hyponatremia, but also, as we discussed, it could be even hypotonic hyponatremia. So how do you figure that out? Well, the first of all is you check for the presence of hyperglycemia, which is the most common cause of hyponatremia with a normal or high osmolality. And if it's not present, then you look for the presence of ineffective osms, such as urea, ethanol, or toxic alcohols, which might increase the osmolality but not the tonicity. And finally, if those are not present, then you look for pseudohyponatremia, which is rare, but that would be the third choice. So that's the way that you should analyze the plasma osmolality. Now, in my opinion, what about the second step of the algorithm, which calls for the analysis of the assessment of the extracellular fluid volume? Well, clinicians are very bad at assessing volume status. And this has been shown in different studies, but this is one particular study that was done back in the late 80s, where they have patients with hyponatremia, and they asked the clinicians to determine if the patients were volume depleted or not, based on their clinical assessment, which included, all the symptoms and signs that you know, poor skin turgor, moist mucous membranes, presence of rales, orthostatic vital signs, etc., etc. And the gold standard to say that they were volume depleted is if they were responding to normal saline. What they were looking for is that the sodium in the plasma should go up by 5 or more after the infusion of 2 liters of normal saline. And as you see there, you have saline responders and non-responders. It's a 2 by 2 table. And if you look at the sensitivity and specificity of the clinical assessment of volume status, sensitivity was 51%, specificity was 53%. So clinicians are as good as flipping a coin when they are trying to determine the volume status of the patient. You also have there the positive predictive value, only 76%, negative predictive value even lower, 28%. And if you like likelihood ratios, they were very close to 1, which means that they don't change the pretest probability of the patient. So volume assessment by clinicians, we are not very good. And finally, the other argument against the algorithm is that the diagnostic yield of this algorithm has been tested. And if you look at the literature, there are many algorithms to assess hyponatremia. The one that we're interested in is algorithm number 8, where you assess sequentially the osmolality in the plasma, then the volume of the ECF, and then finally the urine sodium. If you give this to clinicians, they're able to reach to the correct diagnosis in only 7% of the time. So very poor diagnostic yield. So in summary, what are the problems with the classic hyponatremia diagnostic algorithm? Number 1 is that plasma osmolality is not the same as plasma tonicity. Number 2 is that the clinical assessment of volume status is neither sensitive nor specific. And number 3 is that diagnostic yield is low. I would add also number 4, and that refers to the fact that when you follow the algorithm, you'll end up with one single cause of the hyponatremia. But in reality, hyponatremia is usually multifactorial. You see patients that come with volume depletion and SIADH at the same time. And once you treat the volume depletion, the SIADH is then unraveled and you can diagnose it then. And a combination of things that can happen at the same time. So not usually one single cause, but more than one cause. But for me, one of the major reasons why we should not follow the algorithm is that we should understand the physiology of water when we're talking about hyponatremia, rather than following an algorithm blindly. Very important to do that. Hyponatremia is all about understanding the physiology of water. All right. So, in my opinion, what are the parameters that we need to analyze when we are dealing with hyponatremia? The first one is plasma osmolality, which we discussed initially. The second parameter that we need to analyze is the urine osmolality. But we also, at the end, we're going to analyze urine electrolytes. Urine sodium and urine potassium. Both are important. So let's talk about urine osmolality. Now, before we do that, I would like to point out that it's very important to obtain these labs before giving any therapy to the patient. When we see patients with hyponatremia, they usually come from the ER, and in the ER, patients usually receive 2 liters of normal saline no matter what. And that could have consequences. If you have somebody with SIADH, as we're going to see, they can make the hyponatremia worse by giving normal saline. If the patient has hypovolemic hyponatremia, then by giving normal saline, you're going to turn off ADH and cause a water diuresis that could result in rapid sodium correction, and you're going to have to deal with that later on. So unless the patient is having symptomatic hyponatremia requiring hypertonic saline, the patients really don't need any IV fluids. And you should try to talk to your ER colleagues and talk to them about not giving them, anybody with hyponatremia, giving them fluids unless they need it, because they're going to alter the interpretation of these parameters. So what about the next step, which is urine osmolality? So when the urine osmolality is less than 100, then that means that the kidneys are producing a diluted urine. And that's an appropriate response to a plasma hypotonicity, right? The kidneys are the organs that maintain homeostasis. If your tonicity is low in the plasma, then the kidneys should get rid of free water in the urine and they dilute the urine to a maximal level, which is a urine osmolality less than 100. If that's the case, that means that there is no ADH present, there is no vasopressin in the blood. And that narrows your differential to three things: primary polydipsia, low solid intake, which could be beer potomania or tea and toast diet, or some other form of low solid intake, and renal insufficiency. Now, renal insufficiency is there with an asterisk because in renal insufficiency, you develop hyponatremia because your kidneys are unable to filter normally. So if you drink too much, your kidneys won't be able to keep up and you will retain free water. Now, usually when this happens, the kidneys are able to produce a diluted urine, which means that the urine osmolality is less than the plasma osmolality, but usually they cannot maximally dilute, which means the urine osmolality cannot be less than 100. But they are able to dilute the urine up to a certain point. Okay, so important to remember that. Now what happens when the urine osmolality is more than 100? So when that happens, that means that the kidneys are not producing a diluted urine, and that's inappropriate, right? Because your kidneys should be able to dilute the urine maximally, but if they are unable to do it, then that means that there is ADH present, that there is vasopressin in the blood. And that narrows your differential to three main groups. One would be conditions that cause low effective arterial blood volume, such as hypovolemia, heart failure, and cirrhosis. The second one would be SIADH or cortisol deficiency, right? So remember that cortisol inhibits ADH release. So when you don't have cortisol, ADH is uninhibited. But it's important to think about those three groups of potential causes of hyponatremia. Now, then we need to look at the urine sodium. If the urine sodium is low, less than 20 milliequivalents per liter, that means that your kidneys are sodium avid. And why your kidneys are sodium avid? Because the renin-angiotensin-aldosterone system, the RAS system, is activated. And why your RAS system is active? Because the effective arterial blood volume is low. So when that happens, you have to think of the three conditions that can cause low effective blood volume, which are hypovolemia, heart failure, and cirrhosis. Cirrhosis causes vasodilation of the splanchnic circulation, so that will decrease the effective arterial blood volume. But those three are the ones that you need to think about. Now, if the urine sodium is more than 30, when it's high, that means your kidneys are not sodium avid. Why your kidneys are not sodium avid? Because your RAS system is inactive. And why your RAS system is inactive? Because your effective blood volume is either normal or elevated. So when that happens, you have to think of conditions that cause secondary renal sodium wasting, which is basically a compensatory response that occurs because of volume expansion. And what are those two conditions that you need to think about in this case? SIADH and secondary and tertiary adrenal insufficiency, which means problems with your pituitary and your hypothalamus, where they cannot release ACTH or CRH to produce cortisol in the adrenal gland. Now, let's explain this in a little bit more detail. What do I mean when I say this is a compensatory response? So SIADH, we always said is these patients are clinically euvolemic, but they're euvolemic clinically. At the bedside, when you examine them, they don't look overloaded, they don't look volume depleted, they look just euvolemic. But in reality, patients with SIADH are mildly volume expanded. And that happens because of the initial water retention that occurs from too much ADH. There is a lot of ADH, water gets retained, expands the effective arterial blood volume, And because your body doesn't like to be expanded, then your body reacts by different means. One of them is inactivating the RAS system. Another way is by increasing atrial natriuretic peptide. By the end result is that your kidneys excrete sodium to compensate for the volume expansion. That's what I mean as a compensatory response or a secondary renal sodium wasting. Remember, people with SIADH, the urine sodium is high, right? So that's why it's high. It's a compensatory response to the volume expansion. What about problems with secondary and tertiary adrenal insufficiency? Well, in those patients, there is no cortisol. And when you don't have cortisol, your ADH will be high. The same reason as the patient with SIADH, right? Now, there is a caveat about this condition. There are conditions that you may have a high urine sodium, more than 30, but they actually have a low effective arterial blood volume, not normal or high, as I explained. And those are conditions that cause primary renal sodium wasting, which means that the kidneys are losing sodium. That's the primary problem. It's not a compensation, it's just the primary problem. And the two conditions that are important are, first of all, primary adrenal insufficiency, a problem with your adrenal gland. Why? Because in those circumstances, you not only have cortisol, you also don't have aldosterone. And you need aldosterone to retain sodium in your kidneys. Without aldosterone, you lose sodium, and then you get volume depleted, and your effective blood volume will go down. The other group of conditions are what we call the salt wasting nephropathies, where some insult or drug causes the kidneys to get damaged and lose sodium, and the patient get volume depleted with low effective arterial blood volume. In those patients, for instance, drugs such as cisplatin can do that, but in those patients, you will have a high urine sodium, and if you're not aware of this caveat, you might think that the effective blood volume will be normal or high, but in reality, it's low. So that is the caveat there. You have to be aware of that. So how do I diagnose then low effective blood volume if the urine sodium is going to be unreliable in this caveat? So what I do is I look at other markers of decreased effective blood volume. And those are fractional excretion of urea, fractional excretion of uric acid, and plasma uric acid. So when your effective blood volume is decreased, your proximal tubule is going to reabsorb more urea, the same way or the same idea as in prerenal azotemia, right? And your Fe urea will be low. In this case, the threshold is different, it's less than 55%. Now, the similar thing happens with uric acid. So when your effective arterial blood volume is decreased, your proximal tubule will reabsorb more uric acid, and your plasma uric acid will go up. So your Fe uric acid will be low, less than 12%, and your plasma uric acid will be high, more than 5. So those are other markers that can help you figure it out, the effective arterial blood volume in patients with ADH-dependent or vasopressin-dependent hyponatremia, when the urine sodium is not reliable. Now let's going to talk specifically about SIADH, which is one of the most common causes of hyponatremia. And these are the 1967 Barter and Schwartz diagnostic criteria for SIADH. You have hyponatremia, plasma osmolality that is low, so it's hypotonic, clinical euvolemia, urine osmolality more than 100, suggesting ADH is present, urine sodium more than 30, suggesting normal or high effective arterial blood volume. And one thing that is very important is that your thyroid, adrenal, and kidney function should be normal before you can diagnose SIADH. So that means that you cannot diagnose SIADH in somebody with end-stage renal disease or CKD, because it doesn't matter if you have a lot of ADH, it's not going to do much to your kidneys to retain water, right? As a matter of fact, you cannot diagnose any type of ADH-dependent hyponatremia in somebody with end-stage renal disease. You cannot diagnose hypovolemic hyponatremia, which is ADH-dependent, or any other type of ADH-dependent hyponatremia, because you need kidneys to work in order for ADH to work and cause water retention. Adrenal insufficiency, very important, because sometimes you don't see the typical features of adrenal insufficiency. You don't see hyperkalemia, you don't see acidosis, you only see hyponatremia. So hyponatremia from SIADH and hyponatremia from adrenal insufficiency, they can look exactly the same. So very important to rule out adrenal insufficiency. Finally, normal thyroid function. Well, this is a controversial issue, but in general, severe hypothyroidism can cause hyponatremia. So we're talking about TSHs of over 50 that are associated with hyponatremia, not a TSH of 5 or 10. That's not going to do much in terms of hyponatremia. And the renal criteria also has no use of diuretics within 1 week of evaluation. So talking about other tests required to diagnose SIADH, BUN and creatinine has to be within normal limits. Usually in SIADH, the BUN is less than 10. TSH again within normal limits, but we know it has to be very high to cause hyponatremia. And finally, you at least have to check cortisol in the morning to make sure the patient doesn't have any adrenal insufficiency. And when I do my rounds with my fellows and residents, I usually ask them, okay, so what do you think is causing hyponatremia? And they said, oh, it's SIADH. And I say, okay, did you check a cortisol level? He said, yes. What was it? Was normal. And then I ask him, but tell me the actual number. Oh, they say, oh, it's 12. 12 is not normal. 12 is non-diagnostic. So the rule of thumb that I have for cortisol is if the cortisol level in the morning is more than 18, that practically rules out adrenal insufficiency. I mean, you always want to maybe make sure that they don't have it. Maybe do an ACTH team test, but it's not really necessary. If the cortisol is more than 18, you pretty much rule it out. If the cortisol is less than 3, pretty much that rules in adrenal insufficiency. The patient most likely have AI. But if the cortisol is between 3 and 18, that is non-diagnostic. You have to do an ACTH team test to make sure that the patient doesn't have AI, adrenal insufficiency. All right. Another test that is not part of the criteria, but I usually like to order it, is the plasma uric acid. Because remember, SIADH is a state of mild volume expansion, so you expect that the proximal tubule will reabsorb less uric acid. So the plasma uric acid should be low, usually less than 4. And that is another supplemental criteria that I use to make sure that the patient, that will help you to diagnose SIADH. So I order usually this test in all the patients that I suspect SIADH. So what is my physiological approach to hyponatremia? So the first thing is, once you confirm hyponatremia, you look at the plasma osmolality. If it's 275 or more, consider first of all hyperglycemia, look at the glucose. Consider a hypotonic hyponatremia in the presence of ineffective osms, such as urea or ethanol. Very common. And finally, pseudohyponatremia. If the plasma osmolality is less than 275, that is hypotonic hyponatremia. Then I look at the urine osmolality. If the urine osmolality is less than 100, that means that the urine is appropriately diluted for hypotonic plasma. And that means that there is no ADH. It's a vasopressin independent process. So my three main differentials are primary polydipsia, low solute intake in all their varieties, biroporomania, tea and toast diet, and renal insufficiency, with the caveat that in renal insufficiency the urine osmolality is less than the plasma osmolality, but not less than 100 usually. Now, if the urine OSM is more than 100, that means that the urine is inappropriately concentrated for hypotonic plasma. And that means that there is ADH present. It's a vasopressin dependent hyponatremia. So my next task is to figure it out why vasopressin is there. So I look at the urine sodium. If the urine sodium is less than 20, that means that the RAS system is active, the kidneys are sodium avid, that the effective blood volume is low, and the secretion of vasopressin is physiologically appropriate, because remember, vasopressin is secreted for two physiological reasons. Number one, high plasma tonicity, which is not the case for hyponatremia, right? Because it's hypotonic. And number two, because the effective blood volume is low. So if the effective blood volume is low and ADH is present, that is a physiological reason to secrete vasopressin. And my differential would be hypovolemia, heart failure, and cirrhosis. If my urine sodium is elevated, that means that the RAS system is inactive. That means my effective arterial blood volume is either normal or elevated, and that means that the secretion of vasopressin is inappropriate, right? There is no reason to secrete vasopressin when your effective blood volume is not low. So you have to consider SIADH, right? Syndrome of inappropriate antidiuretic hormone, and cortisol deficiency, which will be similar sometimes to SIADH. So always check cortisol levels. So this is my physiological approach to hyponatremia. Alright, so we'll move to the second part of the presentation. You might recognize this scene of a movie. Yes, this movie is called The Life of Pi. And if you remember from your high school math or your early college math courses, pi is a mathematical constant that is actually a ratio. It's the ratio between the circumference of the circle and the diameter of the circle. So now we're going to talk about ratios. And I have a case. This is Linda, who is 69. She's a retired singer, and she has Parkinson's. She was admitted overnight after a fall, and she developed a right hip fracture as a consequence of the fall. She only takes medications for Parkinson, which is levodopa, carbidopa. Her vitals 130/78, blood pressure, and heart rate 82. Her cardiopulmonary exam is normal, no edema in her legs. She's alert and oriented, and no focal neurological deficits. And her labs are there. Her sodium is 123, BUN is 9, creatinine is 0.7. Her plasma osmolality is 256, so she has a hypotonic hyponatremia, right? Her uric acid is 2.6, her TSH is 1.4, her AM cortisol is 23, her urine sodium is 140, urine potassium is 40, and urine osmolality is 497. So she has hypotonic hyponatremia, her urine osm is elevated, that is a vasopressin dependent hyponatremia, and then we look at the urine sodium, and the urine sodium is 140, suggesting that the kidneys are not sodium avid, the RAS system is inactive, and the patient has a normal or elevated effective arterial blood volume. The differential for that is SIADH or cortisol deficiency. So we rule out the usuals, which is normal kidney function, BUN of 9, creatinine of 0.7, TSH is 1.4, which is normal, and the cortisol is 23, effectively rules out cortisol adrenal insufficiency. So this is most likely SIADH, and you have a couple of extra data there. Your uric acid is 2.6, which is low, also strongly suggesting SIADH. So this looks like SIADH, right? And now the question is, in addition to fluid restriction, which one of the following is the best next step in the management of Linda's hyponatremia? A, no additional therapy. B, normal saline. C, hypertonic saline. Or D, urea. And the right answer is urea. Okay? So we're going to talk about why is urea and not the others. So, but first, let's look at the overall treatment of hyponatremia. So the treatment of hyponatremia will circle around symptoms, right? And the presence of symptoms will tell us how quickly and how do we need to act in patients with hyponatremia. So if the patient has symptoms of hyponatremia that are severe, such as seizures, stupor, and coma, that means that there is a lot of cerebral edema present, and this patient needs to go to the ICU, and you have to treat the patient independently of the cause with hypertonic saline, 3%, 100 ml IV bolus, and you can repeat this up to 2 more times if the symptoms persist. You need to check the sodiums frequently, every 1 to 2 hours at a minimum. Now, if the patient has moderate symptoms of hyponatremia, such as confusion, disorientation, or lethargy, the patient has cerebral edema, not as bad as in the severe case, but still, the patient has to go to the ICU as well, and you can treat the patient with hypertonic saline as well. You could give the patient IV bolus or a slow infusion. My preference right now is slow infusion. There is not a lot of data that one is better than the other. There was a recent study that shows the bolus might be better, but nothing definite yet. So people still could treat moderate symptoms with slow infusion of hypertonic saline. And again, you have to check the sodium very frequently, every 1 to 2 hours. Now, if the patient has only mild symptoms, such as fatigue, nausea, or headache, or no symptoms, that means that the degree of cerebral edema is very mild. And the patient doesn't need to get hypertonic saline urgently. You need to figure it out the cause of the hyponatremia and target the underlying pathophysiology. So if the patient has hypovolemic hyponatremia, the treatment will be to give volume expansion with isotonic fluids. If the patient has adrenal insufficiency, the treatment will be to give him glucocorticoids, right? But you have time. You have to think about the mechanism of hyponatremia and then figure out the best therapy for the patient. Now, in terms of where the patient should be monitored, it depends on the severity of hyponatremia. In my opinion, any patient with a sodium less than 120 should go to the ICU because they need to be monitored frequently, and that's not going to happen in the regular floor. They need to check the sodiums frequently, which will be very difficult to do in a regular floor. If the patient's sodium is more than 120, I think regular floor is appropriate. And the frequency of sodium measurements will depend on the sodium. So if it's less than 120 and they're monitoring the patient to make sure that the sodium doesn't correct very fast, Q4 to 6 hours is appropriate. If the patient's sodium is more than 120, it could be anywhere between once a day to 3 times a day, depending on the severity of the hyponatremia. But now let's focus on SIADH. Okay? So one thing that you need to understand about SIADH is that patients with SIADH have a fixed urine osmolality, which means that the urine osmolality is going to be high, but also a fixed number. So let's say if it's 600, it will be 600 all the time. This is in contrast to people with no SIADH, let's say normal people, where the urine osmolality will change based on your water intake and your solute intake. Remember, if your kidneys are always trying to maintain water homeostasis, so if you drink a lot of water, the urine osmolality will decrease to try to get rid of free water. If you eat a lot of solutes, your urine osmolality might go up. So the urine osmolality is variable in somebody with normal kidney function, but when you have SIADH, your urine osmolality is high and it's a fixed number. Now, what are the components of the urine osmolality? We have urine sodium, urine potassium, and urine urea. Those are the 3 main solutes in the urine. Now, urine urea is a very small amount of the urine osmolality in patients with SIADH. So the major components are urine sodium and urine potassium, which are, if you add them together, the concentrations are going to be about fixed as well. So in the case of Linda, if you add urine sodium plus urine potassium, it's going to be 180 milliequivalents per liter. Okay? Now, we're going to give Linda, let's say we're going to give her normal saline. And you remember that for every liter of normal saline, there is 1 liter of water and 154 milliequivalents of sodium. Linda is going to excrete some of the water of normal saline and the sodium at a concentration of 180 milliequivalents per liter, because remember, this concentration is going to be a fixed concentration. And what you need to understand in SIADH is that people with SIADH have problems handling water, right? They usually retain water, but they don't have any problems handling sodium. So if you give them a sodium load, they should be able to excrete them in the urine because they are in sodium balance. So if you give a liter of normal saline, they should be able to excrete 154 milliequivalents of sodium, but at a concentration of 180 milliequivalents per liter, because that's a fixed concentration. It's not going to change. So in order to calculate in what volume of urine or water will this patient excrete the 154 milliequivalents of sodium at a concentration of 180, then we'll do a simple math. We know that concentration, 180, is equal to mass. The mass of sodium to excrete is 154 divided by the volume. And if you solve that equation, you get that the volume is 0.8 liters. But remember, I gave this patient a liter of normal saline. What happens to the other 0.2 liters or 200 cc's? The patient retains. And that's why normal saline makes the hyponatremia worse, because you will retain certain amount of the volume of water in saline that you're giving the patient. This phenomenon was described back in the 90s and is called desalination. So when you give normal saline to somebody with SIADH, you are desalinating them. You are making the hyponatremia worse. Okay? Now, what happens if I give my patient hypertonic saline. The patient really doesn't need hypertonic saline right now because the patient doesn't have any significant symptoms of hyponatremia, so no need to give hypertonic at this point. So, but let's go over the exercise, okay? I'm gonna give this patient a liter of hypertonic saline, which contains a liter of water, and now 513 milliequivalents of sodium. The patient is gonna excrete the sodium load as in the first scenario when we gave saline, but at a concentration that is 180 milliequivalents per liter. Remember again, patients with SIADH have problems with water handling, but they have no problems with sodium handling, so they will excrete the 513 milliequivalents of sodium in certain volume of urine or water, but at a concentration of 180. If we want to calculate what that volume would be, then we'll do simple math. Concentration 180 is equal to mass of sodium to be excreted, 513 divided by a volume, and if we calculate B, we obtain that B is equal to 2.8 liters. But I only gave my patient a liter of hypertonic, and now he's excreting 2.8 liters, so he's excreting an extra 1.8 liters. Yes, and that's why hypertonic saline works in hyponatremia. Not because it's hypertonic necessarily, but because it makes you excrete free water, which saline doesn't do. So theoretically, if you think about it, you can give the patient any fluid that has a concentration of sodium plus potassium that is greater than the concentration of sodium plus potassium in the urine, and that will make the hyponatremia better. Okay, even patients with SIADH, if you give a fluid that has a concentration that is more than urine sodium plus potassium, then that might make the hyponatremia better. All right, but in general, we should say saline makes the hyponatremia of SIADH worse. Hypertonic saline makes the hyponatremia of SIADH better. Not because it's hypertonic, but because it makes you excrete free water. But hypertonic is not the right choice because the patient is not symptomatic, doesn't need any hypertonic. What about just plain fluid restriction, which was letter A, says no additional therapy other than just fluid restriction? Well, in order to figure it out if a patient with SIADH will respond to fluid restriction, we have to understand the concept of electrolyte-free water clearance. And that's the formula that you see there. CH2O, electrolyte-free water clearance, is equal to B, which is the volume of urine in 24 hours, times 1 minus a ratio. And that's why we're talking about ratios, we said from the beginning. Urine sodium plus potassium divided by plasma sodium. That's the ratio that we're going to talk about. All right. So what is electrolyte-free water clearance? Basically, it's the free water that is contained in the urine. I don't understand that concept. Well, we're going to go over 3 scenarios so you can understand it better. The first scenario is when your ratio is equal to 1. And the reason why we just look at the ratio is because most of the time we're not going to have the volume of urine in 24 hours because in regular floors, most of the time the patients don't have eyes and nose. But again, we don't need to calculate exactly the free water clearance. We just have to look at that ratio and that will give us our answer. And we'll show you how to do that. So when the ratio is in the first row is 1, okay, let's put an example. Let's say somebody's making 2 liters of urine per day. The UP ratio is equal to 1. Then if you calculate the electrolyte-free water clearance, that is going to be 0. What does it mean, 0 free water clearance? The patient is making 2 liters of urine. Yes, but those 2 liters of urine are isotonic to plasma. So that means that you're losing urine that has the same concentration of sodium and potassium, solids in general, to the plasma. And therefore, if you don't lose any free water in the urine or gain any free water, then your plasma sodium should not change, should stay the same. Okay, so let's look at the second row now. What happens when the ratio, this urine UP ratio, or also known as urine to plasma electrolyte ratio, is less than 1? So let's do an example of that. Let's say somebody's making, again, 2 liters of urine per day, B is 2 liters. The UP ratio is less than 1, 0.5. We calculate the electrolyte-free water clearance, and it comes out to be positive 1 liter. It's a positive free water clearance of 1 liter. What does it mean, positive 1 liter? It means that of those 2 liters of urine that the patient is making, 1 liter is isotonic to plasma, but the other liter is pure water. If you put them together, you have 2 liters of hypotonic urine. And if you're losing free water in the urine and you're drinking less than what you're losing, plus insensible losses, then your plasma sodium should increase because you're creating a state of negative free water balance. So your plasma sodium will increase. And that is what happens with the patients who will respond to fluid restriction when they have SIADH. If a patient with SIADH has a ratio less than 1, those patients will respond to fluid restriction. All you need to do is give them less water than what they're losing in the urine and insensible losses, and the sodium should go up. Okay, but unfortunately, those are only about 30% of patients with SIADH. So the minority of patients with SIADH will respond to fluid restriction alone. The great majority of patients with SIADH, 70% of patients with SIADH, will have a urine to plasma electrolyte ratio or UP ratio more than 1. And that's going to be problematic because they might not respond to fluid restriction. And why is that? So let's look at this example. Again, the patient is making 2 liters of urine. His UP ratio is going to be more than 1, 1.5. If you calculate the electrolyte-free water clearance, it's going to be negative 1 liter. What does it mean, negative? Well, let's think about it. Let's say this patient is going to produce 3 liters of isotonic urine. He's about to produce that amount of urine, 3 liters of isotonic to plasma. Let's separate those 3 liters into 2 liters on one side of isotonic and in another side 1 liter of isotonic. Now let's split that 1 liter of isotonic into their 2 components, 1 liter of water and 140 milliequivalents of sodium and potassium, which are the solutes. Okay? Now, what is the patient going to excrete at the end? He's going to excrete the 2 liters that we had of isotonic on one side plus the solutes of the 3rd liter. So it's going to be a hypertonic urine, right? You're getting 2 liters of isotonic plus 140 milliequivalents of solutes on top of that. That's hypertonic. And that extra 1 liter of free water, the patient is going to retain. And because it's retaining it and not excreting it or clearing it, is a negative free water clearance because you're retaining the water. Okay? So if that happens, if you're retaining water, then your plasma sodium should go down. And unfortunately, again, this is the great majority of patients with SIADH. They have a UP ratio that's greater than 1, they have a negative free water clearance, and the plasma sodium will go down. Even if you put the patients on 0 fluid restriction, it's possible that the sodium will go down. And I'll give you an example of that. So, 0 fluid restriction might worsen plasma sodium when the UP ratio is much greater than 1. So let's do an example. We're going to calculate the electrolyte-free water clearance with the formula. Let's say the urine sodium is 200 and the urine potassium is 30. The plasma sodium is 120. If I calculate the free water clearance, it's going to be negative 0.92 liters, right? Assuming that the urine volume is 1 liter. So that means that for every liter of urine that the patient produces, this is a hypertonic urine, the patient is retaining 0.9 liters of free water. Okay? All right, so let's look at the water balance, the I's and O's. The I's, fluid intake is going to be 0 because I'm going to put this patient on 0 fluid restriction. Now, the free water clearance is negative 0.9. Is that going to go in the I's or in the O's? It's going to go in the I's because you're reabsorbing that water. So it's going to go into input, 920 cc's or 0.92 liters. Now, what about the O's, the output? The only output this patient is going to have is insensible losses, which on average is about 800 cc's. If you do the water balance, I's minus O's, you get that the patient has a positive free water balance of 120 mLs or 120 cc's of water every day. Even if you put him on 0 fluid restriction, he's retaining free water. So that is going to make the hyponatremia worse. So if the UP ratio is very high, that even with 0 fluid restriction, your hyponatremia can get worse. So that is the importance of this parameter, this UP ratio. So in 2013, the expert panel of on hyponatremia actually said this, that what are the predictors of likely failure of fluid restriction? High urine osmolarity, more than 500, which is a surrogate for free water clearance. So the higher the osmolarity, the more negative the free water clearance is. And number two, the sum of the urine sodium and potassium concentration exceeds the serum sodium concentration. That's a UP ratio more than 1, which I just mentioned. Okay? So, how do you approach the therapy of somebody with SIADH? Well, you look at the UP ratio and the urine osmolarity. If the UP ratio is less than 1 and the urine osmolarity is less than 500, yes, it's likely that they will respond to fluid restriction alone. So, you put them on some fluid restriction, 0.8 to 1 liters per day, and see how they do. Now, if the patient doesn't meet those criteria, that means they are unlikely to respond to fluid restriction alone, and you have to add a medication, which could be tolvaptan, right, which is expensive. You could also use salt tablets with Lasix, although there was a recent trial that shows that salt tablets with Lasix is as effective as just fluid restriction alone. Okay, and third choice would be urea, oral urea. And we, in University of Pittsburgh, we have oral urea in our inpatient formulary, so we use that as a first choice. So if the urine osm is less than 500, we put the patient on some fluid restriction, 1 to 1.5 liters per day, and start urea at 15 grams twice a day. If the urine osm is greater than 500, that means that they have a more negative free water clearance, so we increase the dose of urea to 30 grams twice a day as an initial therapy. Okay, so this is our initial approach to patients with SIADH. And the last part of this presentation, I don't know if you notice anything strange about that picture there, but you might notice that all the cars have a booth, right? Well, in England, they don't call it the boot, they call it the clamp. So we're going to talk about clamp. And we're going to start with a case. Karen is a 30-year-old singer with a history of hypothyroidism on levothyroxine who developed amenorrhea, followed a few months later by progressive anorexia, abdominal pain, and postural dizziness. On exam, she has a blood pressure of 150 supine and drops to 80/40 standing. Her labs show a sodium of 110, potassium of 5.2, chloride of 75, bicarbonate of 19, BUN of 26, creatinine of 0.9, glucose of 80, urine osmolarity of 650, urine sodium of 60, and urine potassium of 24. And certain treatment is initiated. She was given certain therapy for her condition, and 6 hours later, her sodium is now 116. Came from 110 to 116 in 6 hours. Her urine output has increased to 200 cc's an hour. And her urine osm, which was initially 650, now is down to 105. Okay? So that's the presentation. And the question is actually about therapy. Which of the following is the best next step in the management of Karen? A. Start hypertonic saline. B. Start DDABP. C. Start DDABP and hypertonic saline. Or D. Start DDABP and D5W. And the right answer is start DDABP. Okay. So the diagnosis of Karen was actually, as you can see from her presentation, is adrenal insufficiency, primary adrenal insufficiency. So she was giving probably glucocorticoids, and that triggered the hyponatremia rapid correction. So at this point, the best therapy is going to be to put her on desmopressin. She corrected by 6 in that period of time. So we're going to discuss why this is the right answer, okay, in the next few slides. So what are the goals of limits of correction? Well, it doesn't matter if the patient has acute hyponatremia or chronic hyponatremia or symptomatic or asymptomatic, the goals or limits of correction are pretty much the same. Okay, so the goals of correction is the goals are what you're aiming for to correct. Okay, in the past I used to ask people what are the goals of correction, and they will say 10 to 12, but those were never goals. Those were limits that you should never cross. You are not, when you are treating a patient and you're using a drug, you are not aiming for 1 minus the toxic dose. Like when you're using phenytoin or other drugs that have a narrow therapeutic range, you don't aiming for 1 minus the toxic dose. You're aiming for less than that. So in hyponatremia is similar. You're not aiming for the limit, you're aiming for a goal, what you're aiming to correct by. And the goals of correction are 4 to 6 in any 24-hour period. Okay? If you have acute hyponatremia or symptomatic hyponatremia, you certainly want to reach that goal very fast within the first hour. But if not, if it's chronic or if it's not symptomatic, you could do it gradually over 24 hours. Okay? What about the limits of correction? The limits is what you don't want to cross. In the past, people used to say 10 to 12, and there's still some controversy about that. Some people still say 10 to 12 in the first 24 hours. But there have been case reports where people actually develop osmotic demyelination when they correct by 10 or by even 9. So there is no reason to correct anybody by more than actually 8. So the limit of correction, in my opinion, is going to be no more than 8 milliequivalents in any 24-hour period. And this is important because after you cross 8, you should actually intervene to try to relower the sodium as much as possible, right? Just below the limit of correction in this case. So, who is going to correct fast? We have to know which patients are at risk of rapid correction. And the main reason of rapid correction has to do with the mechanism of hyponatremia. All of these reasons or risk factors that I basically list there, with the exception of the first one, are basically hyponatremias that are mediated by ADH. And what happens is that whatever is causing the ADH to be active or elevated or turned on, once you treat that, it's going to make the ADH to turn off. Vasopressin will turn off. And once vasopressin turns off, there is nothing retaining the water in the body by the kidneys. So if there is no factor that retains water, then the kidneys are going to start to excrete the water. And one of the things that's going to happen, one of the early indicators of rapid correction, is that the patient's urine output is going to start increasing. Okay? And not only that, if the ADH was making the urine osmolality high at the beginning, now that there is no ADH and the urine is diluted because you're pouring water out, like in this case, right, the urine osmolality will drop, right, which was the case of Karen. Okay, but basically all of these factors are, you basically address the underlying issue causing high ADH. Once ADH goes away, water diuresis happens, urine osmolality goes down. So when you treat hypovolemia, the urine osmolality goes. You give the patient a few 100 cc's of saline or isotonic fluid. ADH turns off. Water diuresis happens. If you give somebody with a renal insufficiency, which was the case of Karen, glucocorticoids, hydrocortisone, then the lack of cortisol was making ADH to be high. Now that there is glucocorticoids, ADH is going to turn off. Water diuresis happen. If you have a form of SIADH that was transient, such as pneumonia, you treat the pneumonia, eventually ADH will turn off and water diuresis will happen. If you are post-op after surgery, with pain and nausea, initially ADH is high, but once the post-op state resolves, then ADH will be turned off and then people develop water diuresis. If you stop a thiazide, which might be causing volume depletion, or if you give somebody desmopressin and then you stop it, those will also cause ADH to be turned off and water diuresis will occur. And when you start abaptan, you're blocking ADH actions all of a sudden. That will be the same mechanism. You're turning off ADH, water diuresis will happen. Actually, baptans have been associated with rapid correction of hyponatremia. There are even a few cases of osmotic demyelination syndrome associated with baptins that are reported in the literature. The first one, low solute intake. What is limiting the water diuresis in low solute intake is not so much ADH, because low solute intake, as you know, is a ADH independent or vasopressin independent hyponatremia. But what is limiting the water diuresis is the low solute intake, because remember, solute intake determines the volume of urine. If you eat more solutes, you will produce more urine volume. You know, think about hyperglycemia and glucosuria causing polyuria. The opposite of that would be when you eat very little, your kidneys are limited ability to produce urine volume or water. But now the patient is in the hospital, you give him regular hospital food or a hamburger, now the solute intake goes up, and now they're able to excrete all the water out and they will correct. And it would be even worse if you put those patients on normal saline, which will make them correct too fast as well, because you're giving them solute, you're giving them sodium, which is a solute. All right. Now, not all the patients who rapidly correct will develop demyelination. There are risk factors that need to be present in order to develop demyelination. What are those risk factors? Well, very low sodium, less than 105, alcohol use disorder, cirrhosis, malnutrition, and hypokalemia. Those are the patients that you have to be particularly careful when they correct very fast, because they could develop demyelination. Now, how do we deal with patients with severe hyponatremia? I'm talking about patients with sodium less than 120, which is what you're going to see in the hospital. There are three strategies that we use what we call the DDABP clamp, or use DDABP. So let's explain. So the first one is the proactive strategy, which is the preferred strategy, I would say. The curve in blue is when the patient comes with a sodium of 108 and it corrects very fast up to 132, which is a correction of 24 milliequivalents per liter in 24 hours, which is very bad, right? Now, if you correct the patient gradually, which is your goal is to correct by 4 to 6. We're going to say 6 is our goal. If you start in 108, you want to correct like the orange curve to 114, which will be a correction of 6. How do you do that? The first thing is we have to prevent water diuresis. So how do we do that? Well, we give the patient artificial ADH, which is DDABP, and we give them scheduled intervals every 6 to 8 hours. So in that way, we know that water diuresis it's not going to happen, because we are putting the foot on the brake. We are putting a clamp that is going to prevent any kind of water diuresis. You're giving ADH or artificial ADH on a scheduled basis. Now, if we don't do anything else, the sodium is going to stay there. So how do we make the sodium to go up then? Well, we can start the patient also at the same time, concomitantly, hypertonic saline. We give a slow infusion, which will make the sodium to go up gradually up to our desired goal, which will be in this case 114, a change of 6. Okay? So this is the proactive strategy. This is the strategy that has been shown in a systematic review to be the one that is associated with the least amount of overcorrection of all the strategies that I'm going to mention. Okay? And you have to, when you do this approach, everybody has to be on board. The nurses, the intensivists, because this has to be done in the ICU. Oh, I should mention that there is no data that supports the fact that hypertonic saline has to be given by a central line. Hypertonic saline can be safely given through a peripheral IV. And there's a lot of studies that show that the rates of side effects or adverse events associated with hypertonic saline are similar to any other IV fluids. Okay? Now, the second strategy that also uses the clamp is called the reactive strategy. Okay? Again, my two curves, the blue curve is the one that overcorrects up to 24 milliequivalents in one day. The orange curve is the one that you don't start from the beginning, the therapy, but you are catching the patient, in this case, 6 hours after, when the sodium already corrected by 6, right? From 108 to 114, which is your goal, okay? So if the sodium corrected already by the goal, then the sodium doesn't need to go up higher. I already have the sodium at the level that I want. So all you need to do is just prevent further correction. And as we know, correction happens because of water diuresis. So what we're going to do is just put a clamp here, and we're going to give DDAVP only at scheduled intervals. So I have the sodium around the same value, which is around 114. So at the end of 24 hours, my sodium will only correct by about 6. This is called the reactive strategy. Okay. Now, the second 24 hours, I can now go back and use the first approach, the proactive strategy, and continue the slow correction of DDAVP with hypertonic. Okay, but this reactive strategy, you are catching the patient a little bit late in the game. If you don't do anything, they're going to cross the limit. But if you intervene by giving DDAVP at scheduled intervals to maintain your sodium at the same level that you already achieved, in this case is 6, then you should be fine. And finally, this is the approach that is the least desirable. It's called the rescue strategy, which is when overcorrection already occurred, when the sodium went already over the limit of 8. In this case, the sodium has gone up from 108 to 123, so a correction of 15. That's over the limit of 8. So what do I do then? First of all, I have to prevent the sodium from further increasing. So I put the DDAVP clamp there. Again, I use DDAVP and clamp, so there is no more water diuresis. Okay, but now the sodium is going to be stuck at 123 if I don't do anything else, and it's already over the limit. What can I do? You need to bring the sodium down, and for that you add D5W, and that will decrease the sodium, right, along with the DAVP to at least just under the limit of 8, which in this case will be just right there at 116, which is a correction of 8 in 24 hours. Okay, so that's what needs to be done. This is the least favorite approach. This is when you're getting called later on in the game, and this is not the desirable approach. You should try to always do the proactive approach and rather than the rescue strategy, which is sort of like when you're intervening late in the game. Overcorrection already happened. That's not ideal. So what are the 3 strategies to prevent and treat overly rapid correction? Well, the first one is the proactive approach that prevents overly rapid correction of hyponatremia. When do you use it? At the outset of sodium correction in patients with severe hyponatremia less than 120, and if they have high risk of rapid correction, the risk factors that I mentioned, and or high risk of osmotic demyelination. And you use the DAVP, the dose is 2 to 4 mics, IV, Q6 to 8 hours, and you give hypertonic saline slow infusion. Now, the volume of hypertonic saline can be calculated by the different formulas that you know, sodium deficit formula, Adrogues-Medillas formula, etc. But those formulas have been shown to be inaccurate in predicting sodium. So one simple way to estimate how much sodium to give is just do a simple weight-based assessment or calculation. It's 1 to 1.5 mLs per kilogram. So if the patient is 80 kilograms, you use 1.5 mLs per kilo, that will be 120 mLs of hypertonic. And you infuse that over 6 hours. So 120 mLs over 6 hours is a rate of 20 mLs an hour. And that amount of saline of 120 mLs is supposed to increase the sodium by 1 milliequivalent per liter. You do it over 6 hours because every 6 hours, if the sodium goes up by 1, then at the end of 24 hours, it will go up by 4, which is within your goal of 4 to 6. Okay? You should check the sodium frequently, again, as I said, every 1 to 2 hours. Do not react to one single sodium value because sometimes there are outliers. Try to, before you change anything, try to at least wait and look at the trend over 6 hours and see where your sodium is going before you do any changes to your rate of sodium. Sometimes we have outliers and we just we act as a reflex and try to change the sodium, hypertonic saline. So try not to do that. Try to just look at the trend over 6 hours and see what you need to do. All right. The second approach is the reactive approach, which is to prevent overly rapid correction of hyponatremia. And you started when there is a worrisome sodium trajectory, which means that usually the sodium achieves its goal of 4 to 6, or the patient is very, very polyuric, a urine output of more than 1 ml per kilo per hour. In that case, you just use DDAVP, 2 to 4 mics, IV, Q6 to 8 hours, like in the case of Karen. And finally, the rescue strategy is when the overcorrection already occurred and it went over 8 in 24 hours. In that case, you have to not only clamp the water diuresis with DDAVP, but also relower the sodium. And we used a rate of or a volume of D5 of 3 mLs per kilo IV. So if you give that in 1 hour, that should decrease the sodium by 1 milliequivalent per liter. So you can calculate for how many hours you need to run. So for instance, if somebody has a 80 kilogram, you will need to give 80 times 3. That would be 240 cc's an hour of D5, and that will decrease the sodium by 1 every hour. So my take-home messages are, number 1, that the plasma osmolality, urine osmolality, and urine electrolytes are essential tests to properly diagnose hyponatremia, and they should be obtained prior to institution of any therapy when possible. So talk to your ER colleagues, tell them do not give any fluids unless they're having symptoms and they need hypertonic, but other than that, there is no reason to give fluids in somebody with hyponatremia. Number 2, patients with non-severe hyponatremia due to SIADH with a UP ratio greater than 1 will likely not respond to fluid restriction alone, and they will require the addition of a drug, which for our hospital will be urea, but you should use whatever is available in your hospital. And finally, the DDAVP clamp should be used to prevent or reverse rapid correction of hyponatremia. And with that, I thank you for your attention.